We might get started given it's 1 minute past our start time. So thank you all for joining us. My name's Alyssa Canning. I'm one of the committee members for ANZSO. Thank you everyone for joining us for our webinar today. We'll start things off with an acknowledgement of country. So I'd just like to acknowledge our traditional custodians on the lands on which we all meet today in our prospective states. And we give thanks to our elders past, present and emerging. Today we have a presentation from Dr. Bruce Campbell. Bruce, I might get you to share your slides. We'll get the slides up if we can.
There you go.
Thank you. So Professor Campbell is the consultant neurologist and head of neurology and stroke at the Royal Melbourne Hospital. So Bruce, over to you.
Thanks very much. It's a great pleasure to talk to you about thrombectomy in a large core ischemic stroke. So we'll talk about some indications for thrombectomy overall, the definitions of large ischemic core, summary of the large core trial data, particularly select two, which I know best of the data, and then some case examples, and I don't have any disclosures. So if we think about where we can do thrombectomy currently, the ICA and M1 have clear-cut evidence right out to 24 hours and in a broad range of patients. Tandem disease, where there's a cervical extracranial carotid occlusion as well as an intracranial occlusion, clearly benefit despite the increased technical complexity of those cases. We have evidence for selected M2, the more proximal and dominant occlusions benefited in a sub-analysis of the Hermes trials. But then we have 3 trials beyond the M2 or in the distal M2 and beyond where they were negative results, not just neutral, but actually harmful in those first 3 trials in MEVO. So it's interesting to think about why that is. Obviously, those occlusions are less common. They have highly variable anatomy. They're smaller, less accessible, tortuous, so potentially increased risk of EVT, and there was an increase in subarachnoid hemorrhage and other hemorrhagic complications in those 3 trials. Against that risk, there is less benefit. So there's less territory at risk. There's a greater response to intravenous thrombolytics, and we certainly have equivocal data, to say the least, at the moment. So there will be more trials. It wouldn't surprise me with technical advantages and more experience and perhaps slightly better selection of patients. For instance, there's some suggestion from the trials that patients with a large perfusion mismatch may have benefited. But at the moment, MEVOs are not routine for thrombectomy. And then the basilar artery, of course, has been done for many years. It was where endovascular treatment was first pioneered in stroke, but until the Boucher and attention studies from China, no one had actually proven it in a randomized trial. So we now have those data up to 24 hours. So we can do thrombectomy up to 24 hours, but that doesn't mean we can waste time, because the proportion eligible, the proportion who benefit drops, so there's no time to waste. So what is this concept of large ischemic core? Is it aspect 0 to 5? Is it aspect 0 to 2? Should we be defining it with perfusion on CT or MRI? And what does it all mean? So when we think about the guidelines, Dutch guidelines originally restricted thrombectomy beyond 6 hours to people with a core less than 25 mils. So they thought anything over 25 mils was a large core. And that was based on the not the inclusion criteria for Dawn and Diffuse 3, but the upper 75th percentile of what the core volumes were in those trials. So obviously, the Dawn and Diffuse 3 trials could potentially go up to 50 mils in the case of Dawn or 70 mils in the case of Diffuse 3, but the majority of patients had less than 25 mils. Elsewhere, most places accepted that given the huge effect size in Dawn and Diffuse 3, we could probably afford to go up to the 70 mils, and that's where things were up until the point of these large core trials. If we think about aspects, it's not hugely popular in Australia. It's insensitive to ischemia early or after stroke onset. It's got very poor interrelator reliability, even among experts and even amongst the same person. As Bernard Jan likes to say, before and after coffee, the aspects can vary quite a lot. And poor volumetric consistency. So 1 point in your basal ganglia is very little tissue and very little clinical relevance, but 1 point in your Broca's area may be quite significant and a much larger volume. If you think about the anatomy of it, if you have a proximal M1 occlusion with excellent collaterals, you'll probably still kill off the basal ganglia, and you might lose 3 or 4 points for that deep territory, which is a relatively small volume, probably less than 30 mils, and clinically not very eloquent. Whereas if you've got a distal M1 occlusion with relatively poor collaterals, you might lose 3 points, but in this case for 3 large cortical areas that has a greater volume and a much greater clinical eloquence. So I think, aspects for all these reasons is suboptimal, and it also only really applies to M1 occlusions, because as soon as you get into the M2, most of those points are not at risk. And if you're in the ACA and PCA, it's completely irrelevant to the aspect score. So we are fortunate now to have these 6 large randomized trials of people with extensive ischemic core. They all use slightly different criteria, slightly different time windows, but they all came to pretty much the same conclusion. And you can see there that the overall effect on MRS-03, so getting back to independent ambulation at 90 days, was very strong. 90-day mortality was actually significantly reduced. So this is not just disability reducing, as most of our stroke treatments are, but life-saving. The independent functional outcome was very strong in the odds ratio. Now, if you look at the absolute percentages, it's a relatively small proportion of patients who become independent when you have a truly large core, but it's still clinically and statistically meaningful. And then symptomatic hemorrhage was, of course, the concern with a large area of dead brain that you're reperfusing. And there is an increase in symptomatic hemorrhage, but that clearly is not translating into mortality or other adverse effects. So that's the summary of the data. What do we think about when we're trying to make these decisions? Because they are some of the more difficult decisions that we have to make in clinical practice. So I'm very interested in where the salvageable and the unsalvageable brain is and how much of it there is, and then how confident we can be about that assessment of core. And I'll spend quite a bit of time talking about the imaging that we can use and how to be a little more sophisticated in interpreting the likelihood of infarction. There's also this thing about the depth. We've talked a lot about the extent, but what about the depth of ischemic injury? Because it is possible that we are partially salvaging some tissue with reperfusion. There was some very interesting data from the original Hermes trials that showed that the volume of infarction at 24 hours actually had very little to do with the modified Rankin outcome. And it was really, the same volume at 24 hours would have a very different modified Rankin based on whether they'd had EVT or not. So something about the depth of injury may have been the reason for that if you're salvaging some of the structural elements of the brain, there's more potential for recovery perhaps. The patient factors are really important in this group. If you've got a frail or comorbid patient, they were not in these trials, and it's clearly not someone who's going to bounce back in the way that these patients in trials who are fit and independent previously would behave. The tolerance of disability is something that varies from rural to metro and in different countries. And if you can assess the patient's tolerance of disability, that is a relevant consideration in making these decisions. And then the time to expected reperfusion. Is this someone in your hospital where you've got an EVT service immediately available, or is it someone you're going to have to transfer potentially for several hours to be able to access reperfusion, and assessing the rate of progression in that time? I just wanted to touch briefly on intravenous thrombolysis for large core. It's not really the topic of this talk, but it often comes into the consideration. And by definition, if you've got a large core stroke, at some stage you will have had a large vessel occlusion. It may or may not still be present. And generally, EVT is the definitive therapy if it's available. IVT has pretty limited efficacy in ICA-T occlusion, but once you start getting into the MCA, it does have some effect. Obviously, the main alteplase versus placebo trials excluded people in general with more than a third of MCA hypodensity. So most of the trials that we have did not really include this large core population, at least based on CT criteria. CTP was not done in those early trials. And beyond 4.5 hours, we certainly don't have much evidence until these large core trials about CTP core greater than 70 mils. So we don't have the intravenous evidence from things like EXTEND and TRACE-3 to guide us as to what we should be doing there. Now, it is notable that in the large core trials, 20 to 40% of patients in those trials had intravenous thrombolysis, and that those patients often did better than the ones who didn't, but it's very confounded data. And in many cases, they were patients who were given IVT early on in their course when they probably didn't have a large core, at least on their non-contrast CT. And then they've been transferred for thrombectomy. Then they've been assessed as having a large core maybe several hours later and gone on to have thrombectomy or not in the trial. So I don't think we can use this data very much to help us in the decision. I think we just have to say that if it's a large core evident on the non-contrast CT, that's probably someone that we don't want to treat. There is a hint of that in the IRIS meta-analysis of the direct EVT trials. So those were comparing alteplase in the predominant case against placebo or no treatment prior to EVT. And if they had an aspects of 0 to 5, there seemed to be benefit of not having intravenous thrombolytic on board, but it was a small non-statistically significant subgroup. So if you've got a good-looking non-contrast CT and it's early, I would treat them as per usual with IVT. If it's starting to look pretty dark on the non-contrast CT, particularly beyond 4.5 hours, I would not be giving them IVT, and I proceed directly to thrombectomy on the current evidence. So SELECT-2 was a randomised controlled trial that some Australian sites participated in, had 352 patients when it was stopped for efficacy at the second interim as a planned efficacy analysis. It was a one-to-one randomised trial of thrombectomy using standard devices versus medical therapy. And they had to have an aspects of 3 to 5 or a CT or a DWI core of greater than 50 mils. So you might argue greater than 50 is not that big, and I'll show you some data where we restricted it to a more stringent core. The ordinal MRS was the primary outcome, and there was also 12-month follow-up. So here's the baseline characteristics, a fairly standard age, sex distribution, relatively even distribution of hemispheres, predominantly M1s as usual, and you can see that 18 or so % had IV thrombolytics, but as I mentioned, often well before entry into the trial. Their stroke scale was a bit higher than the standard 17 in the Hermes trials, reflecting the greater core volume in these patients. It was up to 24 hours that they could be randomised. It was reasonably evenly split between the under 12 hours and over 12 hours. You see the aspects had a median of 4. 0 to 2 were not intentionally included in this trial. And the CT volume of perfusion core was in the mid-70s if you just looked at the CTP or DWI. And I'll come back to this idea of composite core, where we looked the larger of the non-con CT or the CTP, which was actually around 100 mils. So significant areas of dead brain in these patients. So there was the primary outcome, a very strong shift on ordinal analysis when the number needed to treat just under 5, which is actually pretty much the same as the Hermes trial in the early time window with small core predominantly. So you can see that the mortality was substantial. Almost 40% of patients died in these trials, and there was no increase in modified Rankin 5, which was gratifying to see. So at least in the trial context where you've got pre-morbidly fit and independent patients, we didn't seem to be increasing the number of patients who went to a nursing home. The benefit is predominantly at MRS3 and a little bit at 4, but there was an increase in independent functional outcome. Now, I mentioned that core of greater than 50 is not that impressive. And so if you exclude people who had either a really good-looking non-con CT or a core less than 70 mils, the treatment effect was the same. It was a very powerful effect. And again, no increase in mortality and no increase in MRS5. But there was an increase in early neurological deterioration, which is interesting. So the NIH increased more than 4 points significantly more frequently in people who got thrombectomy. We'll come back to why that is, but it's essentially about edema. So how can we assess this ischemic core? Because CTP is providing an estimation of the perfusion status at the time of acquisition. It's a snapshot. And so it can overestimate and it can underestimate, and we need to be fairly clear on when we can rely on it and when we can't so much rely on it. CTP overestimation gets a lot of press. It can happen early with fast reperfusion. It's relatively rare in reality. It mostly occurs and affects white matter. And the other thing that can confound this is hemodynamic fluctuation at the time of imaging acquisition. So if the patient happens to be hypotensive at the time you're getting the CTP, you won't see the hemodynamics at their best, and you'll think that the core is larger than it is. What we found was actually much more common in SELECT-2 was CTP underestimation. And this was partly because it included late window patients, and the longer you've gone from the onset of stroke, the more likely you are to have some partial reperfusion or clot migration, for instance, from the M1 to the M2 segment. You can often see collateral improvement despite persistent occlusion as time passes. And what we noticed that there was often poor contrast. Well, there there were other technical factors with the CTP, like CSF space not recognised as brain, or severe hypodensity that was marked as CSF space, poor contrast to noise, and incomplete brain coverage. So here's an example of someone where you look at the perfusion, and there's clearly a fragmentation of the perfusion lesion, where the clot's gone from one single proximal thing to two, at least, proximal distal fragments. And these vessels here have reperfused. And you can see on the non-con, just by eye, that there is a large area of contiguous and confluent hypodensity there, which we've outlined to make it easier, which measured 164 mils, but all we're getting on the CTP is 52 mils. So there's a clear incongruency between the CTP and the actual non-con. And if you can be confident about non-con CT hypodensities, I think you could here, then that trumps anything you're seeing on the CTP. So these late window patients frequently had unrecognized non-contrast CT hypodensity and much larger cores, and that's why the CTP average core volume was 75 mils, but it was about 100 mils when you took into account people with extensive non-con changes. Here's another example. This patient has still got their occlusion here, but there's probably been some collateral improvement, and you can see that there's this volume of 251 mils, including some cerebellar lesion, which was not picked up here. And so clearly the 47 mils is not representative of the entire ischemic burden. What about the severity of injury? So here's someone that you can be very confident has lost their hemisphere. There's zero CBV, there's zero CBF. There are no collaterals at all in that hemisphere. And if you look at the time curves, it's a perfectly normal, well-acquired scan. So when there's this sharp border around the CBF and the CBV lesion, you can be very confident that there is no blood flow getting to that hemisphere. That will die very rapidly, unless you've just iatrogenically caused this during aneurysm coiling or something. You are not going to be able to solve that brain. And if you look at the various thresholds that you get from software, not only the 30% that we typically use, but the 20% is still huge. The CBV thresholds are large and congruent with the CBF, and the Tmax 10 is very large as well. So everything's telling you that this is unsalvageable brain. And although we sometimes still treat these patients if their non-con CT looks good and they're early on, I'm yet to see anyone salvage anything meaningful, and they swell very rapidly and usually expire. Whereas this patient here is a very different pattern. You can see that there's an 88 mils of CBF less than 30%, but if you go to 20%, it drops way down to 7 mils. If you look at the CBV, it's much smaller than that 88 mils, and there are collaterals getting into that area. In fact, if you just look at it visually, the CBV is always the most reliable thing to look at visually, and the anterior temporal region there looks like it's dead, and there's an area here in the operculum that looks like it's dead, but the rest of it looks remarkably preserved. So this is someone that, if you can get the artery open quickly, and that's the caveat, you may salvage a little more than you expected. So sure enough, here's the patient's scan the next day, and that anterior temporal lobe, as we said, was dead, and the opercular region just there was dead, but the rest of it looks remarkably good. Now, there are some caveats with that. When you've had a thrombectomy, there is always some residual contrast staining, and sometimes that's very obvious and you see a bright white stain, but in dead cortex, you will still get a little bit. If you do a dual energy CT, you'll be able to see the difference. And so this is probably not quite as good as it looks because of some residual contrast staining. The term ghost core gets used a lot, and this may be a case where there was a little bit of ghost core, but we've got to remember that CT is insensitive versus diffusion MRI. Had we done a diffusion in this patient, we would have almost certainly seen some cortical ribboning diffusion restriction. The trick with diffusion, of course, is that if you do it too soon, then you see temporary reversal. So had we, for instance, taken this patient for a thrombectomy and done a DWI within a couple of hours afterwards, you might expect to see very little at all on that scan. But then if you do it another day or so later, it'll all come back. I mentioned the residual contrast problem. It's almost universal after EVT, and it hangs around for 24, 48 hours. May not be visually obvious, but it's going to mask the hypodensity. So dual energy acquisitions can be helpful for that. I think in this case, some white matter salvage probably occurred, but it is an oversimplification to regard this as dead or alive. And I just wanted to show you I thought I was going to show you, I haven't got that slide, sorry. But if you looked at the patient's imaging 3 months later, there was actually atrophy in that hemisphere. So even though it looked like a lot of the cortex had been saved, and the patient did improve, their stroke scale went from 20 down to 3, but they had atrophy of that hemisphere. So there is a gradient of injury. It might have been more selective neuronal loss in some areas, and it was clearly beneficial to reperfuse the patient. But we want to think about that dichotomy being not quite as simple as we'd like it to be. All right, so if you look at time, you can see that as time passed, the non-con CT was much more likely to be larger than the perfusion lesion, and that's what I was getting at. This composite core being the larger of the two gave us a much more accurate idea and was much more strongly correlated with the patient's functional outcome. So look at the non-con CT as well as the CTP. That also affects your mismatch definition. One of the caused slight consternation among some of my colleagues was that mismatch did not appear to be associated with the outcome from these studies, and I can go into that in a little more detail in a second, but here you go. So if we look at aspects, 0 to 2 were not really meant to be in the study. Positive point estimate, not statistically significant. 3 to 5 were clearly benefiting. 6 to 10 were not really meant to be in the study. And you can see there the breakdown of individual aspects points. Core volume, clear benefit under 70 and also under 100. And maybe, with over 150, there's a positive point estimate, but it didn't quite reach significance. So really there's no heterogeneity, but we don't have very much data greater than 150 mils of core from Select 2. I'll show you last day in a second. If you didn't have mismatch, your odds ratio was actually slightly numerically higher, although the outcomes in absolute terms were worse. So that's one of these things that whether you have mismatch at either of those definitions didn't seem to alter the treatment effect. And that might be because if you think about 100 mils of core to meet a mismatch ratio of 1.2, you've got to have more than 20 mils of mismatch, and maybe you only need 5 mils of salvage of motor cortex to make a difference functionally. And there's also that idea of the gradient of injury and salvaging some tissue within the core may be relevant. So there's the probability of an independent functional outcome by core volume. It is still one of the strongest prognostic factors. You can see the rate of good outcome dropping down even with EVT, but there's still this hint that you've got benefit at least up to 150. And then 0.3, again, clear benefit up to that sort of 150 mark and not too much data beyond that for independent ambulation. So we put the first 3 large core trials together, Select 2, Rescue, Limit Japan, and Angel Aspect. And you could see the Rankin bars under 70 clearly benefit, 70 to 100 clearly benefit, 100 to 150 clearly benefit, and then beyond 150, not much data, but consistent trends to really massive mortality in that group. Clearly, 2/3 of the patients still die despite thrombectomy, but no concerns about the Rankin 5s and very few people getting back to Rankin 3 or less. So then we had the last day trial. Now this was an early window trial, so it's not like Select 2. It didn't go all the way out to 24 hours. It was 0 to 7 hours, randomized within 6.5. They could include aspect 0 to 3 if they were younger. So again, early and younger patients than the other trials, and half of the patients had an aspects of 0 to 2, most of them using MRI. So it's a real aspects wipeout of that hemisphere. And you can see here that there was clearly a benefit, even people with more than 150 mils of diffusion lesion of thrombectomy, if they were relatively young and robust and early. So that's the caveat with last day. So this is something we did in Select 2 just to illustrate that point that if you have a larger core, you need to be relatively young, you need to be pretty fast in order to salvage a meaningful clinical recovery, in this case, the Rankin 0.3. I think that makes sense clinically, and it's relevant to if you're in a mothership or a transfer situation, how long it's going to take you to get that artery open. And age is not, clearly just chronological, it's their biological age and their frailty. Comorbidities. So we have some of our colleagues, particularly in North America, who think we should just treat everyone, open the artery, and then deal with the mess later, because there's no net harm in these trials. The time taken to select patients is detrimental for those who will benefit and probably doesn't make a difference for those who won't. And you can make decisions about prognosis in the coming days. The alternative viewpoint is that individual patients may be harmed by reperfusion. I think we've all seen examples where accelerated edema and hemorrhagic transformation probably have led to the patient's more rapid demise than otherwise would have occurred. Futility can sometimes be clear-cut. It's often hard to make these decisions in the heat of battle, but sometimes it's pretty obvious that someone who's already in a nursing home or is comorbid or has such a huge core that it's extended into the other hemisphere, for instance, I don't think anyone's going to argue they're going to walk out of hospital. And resources are finite. So if we exhaust, even if it's not the financial resources, but if we exhaust our interventionists, they may not do such a good job on the next case. So are there patients who do worse with EVT than with conservative management? I think the answer is yes, but trying to find them is the challenge. Can we identify them without time penalty? Can we modify then the reperfusion injury trajectory are some of the open questions. So to touch on this is work that Vignan Jogan Draken and I did with hypodensity on the non-con CT and the very severe hypodensity that was less than that found in normal grey matter. And you can see that if you look at the interaction with independent ambulation, there was a significant interaction if you had severe hypodensity. So if you had more than 26 mils, less than 26 Hounsfield units, very hypodense material, those patients did not do well. They had no benefit of thrombectomy, and they had an increased risk of needing a hemicraniectomy as well. So you can see there no benefit on that shift, whereas a very strong benefit if they had a small amount of severe hypodensity. There's the decompressive hemicraniectomy data. So with greater than 26 mils of severe hypodensity, you had a 30% versus basically double the risk of needing a hemicraniectomy if you gave them EVT, and it worsened their edema. And that's what this early neurological deterioration we saw in SELECT-2 was. It's edema from reperfusion injury. So I've talked about the key questions: the extent, the location, and the depth of injury. What's salvageable, what's not salvageable, what does that translate to in terms of the patient's likely deficits? It is prognostic, but not treatment effect modifying. So we need to use our non-con CT and our CTP in conjunction to get the best estimate of what is damaged, and not just the pink or whatever color your software puts out, 30% CBF, but thinking about how reliable is that compared to some of the other thresholds we see, particularly 20% CBF and the CBV thresholds. The partial salvage concept, I think, is really important, and it's very hard to prove, but there are a number of lines of evidence that suggests that partial salvage within what we've traditionally regarded as core may be driving some of the functional benefit for patients. This idea of the patient factors, the frailty and the comorbidity, their tolerance of disability, and the time to reperfusion and the rate of progression in the interim are really important concepts. So I'm going to give a few cases now. This is the first one many years ago, well before these large core trials. 24-year-old guy, fit out playing soccer, collapsed with a dense left hemiparesis, a stroke scale of 20. He'd had some congenital heart disease. He wasn't taking any anticoagulants, and this was his scan. So even 80 minutes after the onset of his stroke, we could already see non-contrast CT changes evolving down in his temporal lobe there. But this is a very young guy. He's got a severe stroke. It's early. We treated this patient without any question at the time, even without those large core trials. That's just the 40-40 stroke window. If you couldn't see it on the other projection, that there's clearly non-contrast changes evolving there. So very poor collaterals, presumably in his temporal lobe. There's the CBV, which is predominantly temporal damage. The CBF was reduced in a broader area. So some of this higher region here was segmented as core. There it is. So it was estimated to be an 86 mil core. And the CBV here was also fairly large. So, somewhere in that 50 to 80 mil range, depending on which threshold you like to look at. He had poor collaterals in that area, as you might expect. And he had the malignant profile, which is the Tmax 10 second criteria, which I think really relates more to the rate of progression rather than anything if you can get fast reperfusion. So we reperfused him, and there was a good result a couple of hours after onset. Here's his DWI. So it wasn't ghost core. He did infarct a large chunk, and it probably was about the 86 mils that was estimated by the CBF threshold. But his NIH had come down to 1 for a slight facial droop. So why was that? Well, you can see that he spared his primary motor cortex, and his corticospinal tract must have still been intact going through that region. And he didn't swell very much. So that was the benefit of the early reperfusion, was that the tissue damage to the blood-brain barrier was minimized, and the swelling was not too severe at all. So he didn't need a hemicraniectomy. He didn't need inpatient rehab. He went directly home on day 4 and was able to return studying and getting good marks. He did have the predicted large core, but he was able to compensate well because of the age and location. So here's another case, also a very young patient, but in this case in Mildura, which for us is about a 5-hour transfer away. And this patient was found having reversed into a barrier with a severe deficit. And you could see on their scan up in Mildura, they already had these evolving changes in the left hemisphere. That's much more eloquent tissue than our previous soccer player. So when they arrived with us, they had a 73 mil core. Now this was actually the week that we were going to present the Select 2 results. So a 73 mil core in someone up in Mildura was still a little bit borderline at that stage. Now we wouldn't have thought twice about it, but this took a bit of persuasion, and I know something that I can't tell you about just yet to persuade the interventionist to do the case. It was also, you know, a good reperfusion, but in this case about 10 hours after the onset. So you can see here, day 1 hour post DSA, there's that contrast staining, in this case, very obvious contrast staining, and you can see the area which has a broken down blood-brain barrier. 8 hours post DSA, you're starting to get quite a lot of swelling, effacement of the lateral ventricle, and fortunately our neurosurgeons were feeling kind to us and took off the bone flap without too much argument, and the brain swelled a lot. Then at 7 weeks, you can see that there's an area of complete tissue liquefaction where that 70 mils of core was, and then some of the larger areas around there had less severe injury. So it's a gradient of injury that you can see even on that non-contrast CT scan between the area that was intensely ischemic and less severely ischemic. And this patient did eventually get back to walking and some level of speech. So another case during COVID, 47-year-old guy, so a bit older, woke with a dense right MCA syndrome. So this is wake-up stroke, and it was in COVID and everything was a bit more complicated. Here is his baseline scan. You can see the hyperdense artery and some early changes there already, not terribly severe. So presumably had just woken up relatively shortly after the ischemic insult, but the CTP is showing a very large core of 151 mils. So this is someone that the interventionist did not want to treat at that stage, even though he's pretty young and the CT looked good, but they were happy to randomize him into Select 2. And you can see that the CBV there, particularly up around the motor cortex, which is the most important thing in these right hemisphere patients, it seems, was actually preserved. So that gave me some hope that if we could get the artery open, we might get some motor recovery. So there was his M1 occlusion. You can see that he had pretty poor collaterals into the bulk of that MCA territory, but the ACA was getting around a little bit to about there with reasonable perfusion. Here's his post-procedure scan, so very nice reperfusion, and there's the lateral, and you can see that's very close to a TICI 3 result. So at 24 hours, what do you think his CT looked like? Well, there it is. So he's got a large infarct, but it's not terribly hypodense just at the moment. And his motor cortex up there, you can see the hand knob still has grey-white differentiation. And then at day 3, we've got more evolution of that edema. But he's escaped without a hemicraniectomy, and again, motor cortex is preserved. Will eventually let me go through to the next slide. Hopefully, there we go. MRI. So what was interesting at day 10 was that you can see the intensity of the ischemia in the temporal lobe. And then milder injury in the cortex up higher, and then sparing that motor cortex with the hand knob there. At 1 year, what do you think you could see? Well, there's complete tissue liquefaction in the temporal lobe, gliosis, and then as you come up, milder levels of gliosis through this region, some ex vacuo dilatation of the ventricle, and then, some more liquefaction in that little area there, but it missed the motor cortex. So this guy had an excellent functional outcome, went back to all his usual activities, and it really is down to the eloquence of the tissue that was affected and rapid reperfusion and perhaps some partial salvage through some of the other areas there. I'm now going to show you some not so happy cases. 59-year-old woman, rural transfer. So there's always going to be this much longer time between the initial imaging and the reperfusion of severe right hemisphere syndrome. And she was direct to angio on arrival. So we didn't re-image, and we often don't now. But that creates a scenario where we don't know how much ischemic evolution has occurred. I think it's very reasonable to say, if it's not going to change your decision to treat, because you don't want to wait half an hour, particularly in these severe patients. But what we often do now is an immediate post-EVT CT to see whether we're already getting some swelling and need to worry about hemicraniectomy, particularly in this age group. So here was the scan on arrival, I believe. And you can see quite extensive loss. Sorry, that was the original scan out in the country. Extensive loss of grey-white differentiation, poor collaterals. These Nico lab maps are not wonderful, but you can see that there is a very large reduction in CBF, also CBV, so it's probably real, and that matches up with the non-con CT. So you can be very confident in this patient that they do have a large core. She'd already partially reperfused on her initial DSA. She had an M2 occlusion, so the M1 had migrated with whatever happened up in the country, and she had EVT, and then this is shortly after the EVT. So there's significant edema. There's a parenchymal hematoma with intraventricular hemorrhage. So she's really got the brunt of reperfusion injury, and you can see that she went on very rapidly then to a hemicraniectomy, which she survived, but it wasn't a great outcome. And I'm not sure whether we helped her or not with that procedure. Another transfer case, slightly older, had an initial scan. This is left hemisphere there, obviously. So not terrible non-contrast CT changes. I think this patient didn't get lysis, but you could have considered it in that situation given the time to reperfusion. But there's the post-op CT showing a lot of swelling. And again, not much hemorrhage in this case. Probably just a bit of contrast, but there's early hydrocephalus, and particularly if you're not going to do a hemicraniectomy for this age group, that's not going to lead to a good outcome. There's the perfusion in his case, so large CBF lesion, large CBV lesion, congruent with the CT changes. You can be very confident that that's a large core. So what might be able to do that in the future? Well, it might be possible to change the trajectory of that reperfusion injury. Now, the CHARM trial overall was neutral. So this is the result that was published in the Lancet Neurology with a favourable trend that didn't go anywhere near reaching significance. But what was done in an interesting post hoc sub-analysis was patients who didn't have a massive infarct. Now, they chose 125 mils based on some sub-analyses of the initial large core trials, but you can see there that the benefit of glibenclamide seems to persist up to about that 125 mil level, and then beyond that, patients just do terribly, and it's very hard to show any benefit. And interestingly, the ones who got EVT, which is a very small subgroup, had a massive treatment effect with glibenclamide. So this deserves some more attention. We're hoping to get a trial up of intravenous glibenclamide in the EVT population with large core sometime in the near future. That really might change the decision-making in these patients where we're worried about reperfusion injury. So to conclude, reperfusion therapies with thrombolytics and endovascular thrombectomy have, of course, transformed the outlook after ischemic stroke, and they're time critical. So it's great that we have extended time window. That's good for people who are unavoidably delayed in presenting, but the proportion eligible is lower, the benefit's lower, so time remains brain. EVT eligibility has certainly expanded a lot. About a third of our workload, I think, is now large core, and it does create some challenging decisions. I don't think EVT for every large vessel occlusion is the right strategy. I think if we can think about the core volume, the location, the confidence we have in that core, and the time that it's going to take to reperfusion, mixed in with the patient factors like their age, frailty, and comorbidity, and thinking about what would be acceptable disability for this individual, will make better decisions. By all means, the default position can be, if in doubt, reperfuse ASAP, because if we can't be sure that the patient's destined for a completely terrible outcome, then we should give them the benefit of the doubt, and we can sort that out later. And a short conversation, because all of this, of course, is time critical, but if we can get some idea of the patient preferences, that may be helpful, mostly when the alternative is almost certain death. So we don't want to transfer people from death to nursing home status. If they're looking like they'll survive anyway, EVT is probably their best chance to reduce that level of disability. We don't always have a choice in the outcome, and less disability is better than more. But these are difficult decisions, and very happy to take some questions. Thanks.
Thank you, Bruce. That was a fantastic presentation. I guess that while the audience are coming with a few questions, I have probably here a couple for you, if that's okay. The first one is the third case that you presented, that a patient that had the right MCA stroke and in the context of the COVID pandemic. You mentioned that was a select 2 patient. Did you have the chance to run your severe CT hypodensity volume analysis on that patient?
Yeah, it's a good question. He would have been in that analysis. I haven't fished him out to see which one he was, but yeah, it's a good question. He had quite severe hypodensity in that temporal lobe, but obviously the preservation of motor cortex was the key thing in him.
Yeah, thank you. I find your paper that you and what you've been working with Vignan on the severe CT hypodensity one of the most exciting things coming. When do you think, how far we are from that to be used on the day-to-day?
Yeah, I think the key to that will really be automated software to do it. And I think there are a number of algorithms now in development, including some local ones, which are getting pretty good at segmenting non-contrast CT hypodensity. And I think that would be wonderful, because we could throw the aspects in the bin once and for all, and have a reliable objective measure of hypodensity that's not just the extent, but also the severity. And I think that is likely to be very helpful in understanding what's likely to happen when we reperfuse a patient. But also, I think we do need to focus on treatments that can ameliorate that reperfusion injury, because as you saw in Select 2, there was an increase in early neurological deterioration, but if you can get through that, then the patients on average did better. So we've got to somehow get these patients through that initial edema hump and through to where they can recover later on.
Thank you, Bruce. Last one before opening to the audience. Hemicraniectomy, you touched base about this a couple of times, usually a quite challenging discussion with neurosurge, but kind of in the continuum of care of the large cause, at least on many patients. Any pointers, anything, any messages to take home about hemicraniectomy?
Yeah, I mentioned that fact that an early post-reperfusion scan can be very helpful, particularly if you've gone direct to CT, direct to angio after a long transfer, which many of us do. And I think just getting that new baseline to tell you whether you've got to worry about this patient overnight or not, because we have in the past had patients cone within several hours of an EVT procedure, which is very hard to retrieve once they're blowing pupils. So I think it's important to get a new baseline to know what you're dealing with, and then to have that discussion with neurosurgeons on a regular basis and try to have a protocol that you've agreed on, that you're not waiting for people to blow pupils before you get them to theatre. We often end up doing, BD CT scans for a day just to try and track the trajectory.
Thank you. Any other questions from the audience? No one coming.
think Lauren might be coming to ask a
Can
question.
you hear us? Can we
Yeah,
talk?
we can.
Right, okay.
Yeah.
Thanks, Bruce, on behalf of the St. V's team. How far away do you think we are from using imaging to individualise the blood pressure targets post-thrombectomy in these cases?
That's a really good question. Everything that's been done with blood pressure post-thrombectomy has been harmful. So I'm currently in the camp of just leave it the hell alone. But you know, clearly some people have residual occlusions even after what looked like a successful reperfusion, and those patients probably are not going to benefit from blood pressure lowering, and they're probably the ones that were harmed. But I don't really think we have enough. The trials that were done of that were the big simple trials. We don't have enough granularity really to understand which patients were being harmed. But certainly, you know, if you look at Interact 4, it's a classic example. If you've got an occlusion, you don't want to dump the blood pressure. So I presume that still applies after EVT.
No.
Any more? No more questions?
No more questions?
Nothing in the chat. Excellent. Not a problem. Well, we might draw this session to a close. Thank you very much, Bruce, for the presentation. That was fantastic. And thank you to all of our attendees online. We had a great turnout. Great to see you all.
Thanks very much.
Thank you. Thanks, Bruce.
Thanks
everyone.
everyone.
Have a nice afternoon.